All right, we are back for some H and P. So the strategy last time, I did okay on the exam. I didn't do great, but I ended up making, I didn't just do Anki for that. Oh, that's a great picture. I didn't just do Anki for that. I ended up doing, I did make some documentation for that, which was this. It was neuro, so it's very difficult to wrap my mind around like what was happening. So I did make this with all the tracks of the nervous system, which ended up really coming in handy for some of this posterior column spinal thalamic stuff. I still got my wires crossed literally for some of these questions, but that's over with. So neuro is over with. We have musculoskeletal now, and I have a practical on this on Monday and then the exam on Thursday. So kind of studying for both of these at the same time. We're going to start with shoulder. So if we look at my flashcards, see a neuro, we have actually have 98 cards in total. That's not bad. Maybe a little worrisome that I don't have enough. Spine and knee aren't complete, so I do have some extra ones to add in there. I'm hoping anatomy is not bad. We've gone through a good amount of some of this stuff, at least the anatomy stuff last semester. So hopefully this isn't too painful. Okay, we're going to start with the shoulder. There's only one slide for documentation, and this is always do general appearance, vitals, and what two other systems with MSK. That's going to be neuro and peripheral vascular. So there we go. There's one card done already. So we're going to start with shoulder in a second. We have 22 cards, 53 slides. I'm going to just read through the slides real quick and just kind of see what do we have. So we have some shoulder anatomy. We have some ligaments, parts of the rotator cuff. We have how age has to do with doing the history and physical here. Some biliary referral with GI stuff that could be important. Nocturnal symptoms, anterior versus posterior inspection. What are we palpating? Range of motion. Where to stand, what frozen shoulder is. Then we have all the special tests, which I have over here on the left as well. So we'll go through those. Impingement syndrome is a thing. It's non-specific. It has 3 stages. There's modified neuroimpingement. It's a special test. We have the supraspinatus strength test, which is the empty can test. Drop arm. Bicipital tendonitis. That is what we test with Jurgensen's. Something called a slap tear. Shoulder instability, recurrent dislocation, something called a Bankart lesion, something called a Hill-Sachs lesion. Then we have 3 tests for shoulder instability: apprehension, relocation, and sulcus. What's relocation? Oh, these are both the same. So these are technically 2 and 1. Okay. And these are all for shoulder instability. Sulcus sign is for shoulder instability. And then they said, oh, so it's apprehension, relocation, and sulcus sign. So it's these, not drop arm. Whatever. Okay, so that's it. Let's get right into the cards that I made during class, see if we can burn through these. Am I recording? Yes, pause recording. Okay. Nocturnal symptoms. Thought to be more common in blank tears of rotator cuff. No idea. Is this anterior versus posterior? I'm going to guess anterior. Oh, complete. Okay, sure. The 4 muscles of the rotator cuff composed of 4 muscles surrounding the joint. I should probably know these. Okay, I think it's just supraspinatus, infraspinatus, teres minor, and then subscapularis, which I believe is like, is it deep to supraspinatus? Whatever. Supraspinatus. Infraspinatus. I think it is deep. It is deep to those. And teres minor. Good. Anything else I need to know here? I don't think. Hopefully that's a gimme question, and it's going to be like teres minor or teres major or something. Scratch test, quick way to generally assess active range of motion. Okay, of the shoulder rotator cuff. In a modified near impingement test, I think this is this. You stabilize the scapula, elbow is flexed to 90 degrees, and humerus is internally rotated. Shoulder is then passively flexed, which would be this. Positive sign is shoulder pain anywhere from blank degrees. It's always like 90 to 120, isn't it? So I'm at 90, any pain up to 120, right? 180 would be this. Generally, pain subsides in full flexion, which would be this. Yeah, 90 to 120. Yeah, I guess full flexion is like this. Clinical pearl, if pain is relieved by a subacromial injection of anesthetic, this further confirms impingement. So if it's this, if it hurts between 90 and 120, then it's a near impingement. Impingement of what, though? Just the rotator cuff. Of like the nerves that go through there. Whatever. Subluxation or dislocations of the glenohumeral joint are more commonly found in which age group? Like kids? Younger than 30. Okay. Drop arm test, instruct patient to fully abduct arms, then slowly lower in adduction. Positive finding if the arm drops from a position of, so 180, I think if we hit like 120 and then we drop to 90, most consistent with weakness tear of the rotator cuff supraspinatus, because I think this is, isn't it like deltoid, and then supraspinatus, and then deltoid takes over? That would make the most sense. Deltoid's fine. Now I need my supraspinatus, and now I'm dropping here. So it should be 90 to 120 or 120 to 90. But it looks like it's not just a drop. It looks like it says there's pain too. Sure. Deltoid atrophy can be due to an issue with which nerve? Pretty sure I got this wrong on the test. Is it C5? Probably not. Oh, axillary. Yeah, I knew that. An avulsion fracture of the anterior glenoid at the anterior. All right, so an avulsion fracture at the all right, so it's everything antero. It's a name, I don't know. You just have to know the name. It's called a Bankart lesion. Axillary view is going to be the best and associated with anterior dislocation and recurrent instability. So an anterior dislocation would be your arm being pulled backwards, I believe, and your glenoid comes forward. So my arm is being pulled back, and then this comes forward. I think that's what an anterior dislocation is. So that's going to be a Bankart lesion. Sure. All right, blank test. Okay, this is one of those like shoulder stability tests. Follows apprehension. I don't remember the name. Adding downward posterior pressure on humerus. This stabilizes the humeral head and the glenoid. Positive finding is when pain or apprehension is, I would assume, worsened with the maneuver. Supports the finding of anterior. So what is this called? This is just called a relocation test. Positive is resistance or pain. But this is where adding downward pressure on, I think you're adding downward pressure, and I think you're pushing this way. Adhesive capsulitis, aka frozen shoulder. Okay. Bicipital tendonitis / tendinopathy most commonly affects the blank head tendon. No idea. Long head tendon. Oh, of the biceps, I would assume. Yeah. Get some pictures could help. There's our long head here. Bicipital tendonitis, occasional snap sound or sensation. And this is tested with what? Yergeson's, which we'll get into in a second. Two combined locations, shoulder pain is the most common complaint. And anterolateral. Okay, lucky guess. With posterior shoulder pain, consider blank referral. Warrants a GI review of systems. Posterior shoulder pain, like biliary. Okay. Yeah, because you can get that sign or whatever from, is it cholecystitis? In impingement syndrome, so this stuff, the painful arc of abduction occurs, between 90 and 120. There we go. In Yergeson's test, that's this, right? No. That's the handshake. That's like the handshake thing. I think you pronate. I hold your hand, and I'm holding here, and you try to supinate, and I'm resisting your supination. I think I'm feeling for like a pop. Yes, can indicate blank tendonitis, bicipital tendonitis. So we're trying to get that long head right over the like the humeral head. And it's transverse humeral ligament instability. Okay. Most common position of instability is the throwing position. So like this, which is I think why we get those anterior dislocations. I assume that's the throwing position and not this. Arm, oh, here we go. Arm abducted at the shoulder, I would assume, and externally rotated. Yeah, there we go. The throwing position. Anterior versus posterior instability. Greater than 95% of instability problems involve blank direction subluxations. I would assume anterior again, right? Yes. Boom. This is coming forward out of my shoulder. Okay. Compression fracture of the posterior lateral humeral head. So compression fracture of the posterior lateral humeral head. So back here, caused by contact between the posterior humeral head and the, what is this question? Oh, okay. A type of lesion. It's called a Hill-Sachs lesion. Yeah, you don't want that. Blank sign, classic test for anterior instability. This is this position patient with shoulder at 90 degrees. I don't remember what this is called. Apprehension. So this one is without, these really are two separate tests. So this is apprehension. Relocation, I need to make its own thing. Position patient with shoulder in 90 degrees of abduction. Slowly, passively, externally rotate shoulder. Positive finding. Resist, have them lay down. This is the arm bar one. Passively, externally rotate shoulder. So we'll talk about relocation when we get to that one. Tear wear biceps tendon attaches to the labrum both anterior and posterior. What are you asking? Oh, tear where the biceps tendon attaches to the labrum. What? Is that supposed to say detach? Tear where, oh no, it's a tear where the biceps tendon attaches. So this is already long head, short head have already come together, both anteriorly, so we're in the front, and posteriorly from attachment point. So it's called a slap lesion. Superior labrum from anterior. Okay. Which shoulder issue can be seen in connective tissue orders like EDS and Ehlers-Danlos? I think those are the same thing, right? I don't know. Recurrent dislocations. Okay. Yeah, that's the same thing. They're also installing new siding about 6 feet from my right. So trying to focus with constant hammering and drilling. So that's fun. All right, blank sign. Is this the sulcus sign when you pull the arm down? It is. This is just an identification. We'll worry about what it means. It's just, that's what that is. Adhesive blank, aka frozen shoulder. Tendinitis, capsulitis. Nocturnal symptoms thought to be more common in blank tears of the rotator cuff. Oh, complete. Deltoid atrophy can be due to an issue with which nerve? That's your axillary nerve. An avulsion fracture of the anterior glenoid at the anterior. This is some type of lesion? Is this Hill-Sachs? Bankart lesion. How are we going to remember that? Avulsion fracture at the anterior. Anterior dislocation. An avulsion fracture and anterior dislocation. Avulsion is just like, what is an avulsion fracture? Like a removal? Yeah, a small chunk of bone attached to a tendon is pulled away from the main part of the bone. Okay. Avulsion fracture, anterior, antero-inferior. So it's kind of like underneath. And you can see that it's antero and it's inferior. Bankart lesion. I don't know. You're robbing a bank and they kind of like, you got shot right here or something. We'll see if we remember that. You have to remember axillary view in the anterior, posterior. I know this is like the axillary area, but what is an axillary view on an X-ray? Um, so it looks like they are like this, and the film is here, and we're maybe shooting down. So I think it just means, and if their shoulders hurt, I'm sure that's going to be painful. So I'm sure they'd give them something, but it looks like they want it kind of abducted at 90 degrees. That's what these pictures are showing. Or there's even another one where the film is up here. They probably shoot it from both directions and then they shoot kind of into the armpit. Okay, whatever. Makes sense. Bicipital tendonitis, tendinopathy most commonly affects the blank head tendon. That's just going to be the long head. All right, so follows apprehension. So this is going to be, was it like resistance? Relocation. So this is the one we have to do. All right, so follows apprehension. But we're adding downward pressure. On humerus, like at the shoulder. And then positive finding is when pain or apprehension is relieved. Oh, interesting. That's actually very important. Because we're stabilizing the issue. Positive finding is when apprehension is relieved. Stabilize it. And again, this is for, what is this for? Just instability? Anterior glenohumeral instability. I think it's the same for both. It's like, hey, do you have it? And then like, let's kind of confirm, I guess. All right, we'll take that. Compression fracture of the posterior lateral humeral head. This is this one from here, caused by contact between the posterior humeral head and the anterior glenoid rim, a type of lesion. So it's not Bankart. Is this the Hill-Sachs thing? Yeah, Hill-Sachs. Okay. So how are we going to remember that? I don't know. It's like you're carrying a sack over the hill in this kind of posterior, and it says anterior though. But the compression fracture is of the posterior lateral humeral head. You know, carrying a sack over the posterior lateral humeral head up a hill. But I think the interesting thing with this is the scapula is like digging into the scapula, the glenoid rim is digging into the humeral head. Like that's crazy. And then what is this? Like after it's fixed? So these are causes of, so a Bankart lesion and a Hill-Sachs lesion are results of recurrent dislocations. So that's probably a good question to kind of like tie this all together. We are in shoulder. Can cause these two bony labral lesions. So we know Bank is more from the front, Hill-Sachs is more in the back. So seeing the bigger picture here. And not only that, but yeah, Bankart is definitely more inferior. They're almost complete opposites. Hill-Sachs is more back here again, but that sack over the hill. Hopefully that's enough to get this question right. Good. So Bankart's and Hill-Sachs. There's lesions. Compression fracture of the posterior lateral humeral head sounds like Hill-Sachs to me, caused by contact. Yes, okay. Tear where the biceps tendon attaches to the labrum, both anterior and posterior from attachment point. Oh, yeah. What was this called? Something weird. Oh, it's a slap tear. Okay. Blank sign, classic test for anterior instability. All right. Are we putting pressure on or not? No. So this is going to be just apprehension is the first one. Okay, it's just alphabetical. Apprehension, relocation. Which shoulder issue can be seen in connective tissue orders like Ehlers-Danlos? Just like recurrent dislocations. There you go, which then can cause Bankart or Hill-Sachs. Adhesive, it's not tendonitis, it's capsulitis, aka frozen shoulder. Okay, scratch test, Pukveda generally says active range of motion. So it's active when they do it and passive is when we do it. Pretty sure that's correct. There's no one else in that picture. The four muscles of the rotator cuff, supraspinatus, infraspinatus, subscapularis, and teres minor. Is that correct? Yes. An avulsion fracture of the anterior glenoid at the anterior inferior aspect. That's a Bankart lesion. That axillary view. Drop arm test, instruct patient to fully abduct arms. Positive findings, arm dropped from a position of 120 to 90. And that's going to be a supraspinatus issue. We didn't get into the empty can test yet, so maybe I did not have a card for that. Tear where the biceps tendon attaches to the labrum both anteriorly. Is this slap again? Okay. In a modified near impingement test, that's this. Stabilize the scapula, elbow is flexed to 90 degrees, and humerus is internally rotated. Positive anywhere from 90 to 120. It's like the answer for all of these. And generally pain subsides in full flexion. Okay. Subluxation or dislocation of the glenohumeral joint are more commonly found in which age group? Anybody under 30. Shoulder pain is the most common complaint. 2 combined locations. I think it's anterolateral. It's the shoulder. With posterior shoulder pain, consider blank referral. So this is where you're going to have biliary referral. You want to do a GI review of systems, rule out like cholecystitis and stuff. Adhesive capsulitis, aka frozen shoulder. I like cards like this where there's a closed deletion on 2 parts of it. In the past, I've only closed deleted like frozen, and I've not remembered capsulitis. I just remembered like adhesive something. So hopefully that will help. All right, Jurgensen's test. What is Jurgensen's test? I think this is the old handshake, right? Yeah. Positive finding is a pain or pop in anterior aspect of shoulder. This indicates bicipital tendonitis. Patient does the action of the biceps muscle, which is going to be supinating, which is going to be this, doing like a bicep curl, right? Supinating, coming up like this. And if we hear a pain or a pop in the anterior aspect of the shoulder, they're going to have bicipital tendonitis or transverse humeral ligament instability. In impingement syndrome, the painful arc of abduction occurs between 90 and 120. Right, because it's the rotator cuff. That's the issue. Supraspinatus. Most commonly, position of instability is the throwing position, arm abducted and externally rotated, anterior versus posterior. Greater than 90% of instability problems involve anterior subluxations. This is just sulcus sign. Deltoid atrophy can be due to an issue with which nerve? Axillary. Nocturnal symptoms thought to be more common in complete tears. Bicipital tendonitis, tendinopathy most commonly affects the long head. Compression fracture of the posterior lateral humeral head. Sounds like Hill-Sachs, caused by contact between the posterior humeral head and Hill-Sachs. Blank test follows apprehension. So this is, starts with an R. What is it? Relocation. So I'm putting pressure on here. Positive findings when pain or apprehension is relieved. So now we are Doing this again, if it is relieved, then it's what is the problem? Just instability? Yeah, just anterior glenohumeral instability. I don't know why I can't say that. So apprehension first, and then you stabilize and you do relocation. Recurrent dislocations can cause these two bony labral lesions. This is going to be Hill-Sachs, and this is going to be Bankard's. Which shoulder issue can be seen in connective tissue orders like Ehlers-Danlos? Just recurrent dislocations, adhesive capsulitis, aka frozen shoulder, an avulsion fracture of the anterior glenoid at the antero-inferior aspect. Avulsion fracture, this is a Bankard lesion. Blank sign, classic test for anterior instability. This is the first one, so apprehension. Tear where the biceps tendon attaches to the labrum, both anterior and posterior from attachment point. Oh, slap tear. That's it. Okay. Are there more details that I probably missed? Probably, but this is the basics for shoulder. I did miss, I didn't do any empty can stuff. So did I just miss that? No, can is not here. Here we go. Supraspinatus strength test. It's just this downward pressure applied to the patient's arms. Positive finding is weakness or apprehension. I mean, okay. I feel like that one's kind of a little bit more self-explanatory, but if it's a test, I might as well have a card on it. All right, so we could do one of these. I like not having a picture so I can do this myself. Downward pressure applied to the patient's arms. Positive finding is just, yeah. We'll do that, and then we'll throw the picture in here. Empty can test. We can even do, we'll do a close on the word supraspinatus too, so we can make two connections. It's probably 90, arms brought forward, flexed. Duck patient shoulders to 90, arms brought forward. I guess they're saying this is 45-degree flexion. It's 90 degrees to me. Flexed, whatever. I'm not going to overthink it. Card is complete. That's shoulder. All right. We'll revisit that later. I want to, if I can knock out the elbow, that would be good. So if we're following along on the left, elbow is here, only two special tests. This should be easy. Second PowerPoint. All right, let's take a little break. We'll come back. I'll read through the elbow slides. There are only 33 of them. Really shouldn't be too bad. And then we'll go from there. Okay, we're back. So let's see if we can knock out the elbow. Like I'd mentioned, there are 33 slides here. So let's do a little run through to see what we have. So the elbow is a hinge joint with 3 bony articulations. Three. Lateral, medial, and like the olecranon, I would assume. It has some stabilizing features. It has 4 zones that are the muscles of the elbow. So we should know what those are. My elbow hurts. Visual inspection. We have rashes. We're inspecting. Cubitus varus versus valgus. Olecranon bursitis is a thing. Positive Tinel sign. So that's going to be when we get into the wrist, but it's just mentioned here because of the tunnel it comes from. Lateral epicondylitis is a big one. That's our tennis elbow. Medial epicondylitis, that's going to be our golfer's elbow. Fine, here, put it right here. Go ahead, take it. Range of motion. Make sure you're pronating and supinating the elbow, not the wrist. Clinical case, nursemaid's elbow. That's a big one. Okay, this one shouldn't be too bad. What I do want to do is make sure we have everything here. Are we inspecting for anything that's kind of really out of the ordinary here? No, I think it's the same. Inspect for abnormalities, swelling, erythema, ecchymosis. Swelling, erythema, ecchymosis. Oh, nodules. We are adding nodules here. And nodules. So elbow. Swelling, erythema, ecchymosis, nodules. So there's 4. Oh boy. All right. And then palpating the elbow. Deformities, tenderness, and muscular hypertonicity. Okay. It's bilateral. Of course. Active range of motion. There's going to be 4. So flexion, extension, pronation, and supination. So flexion, extension, pronation, and supination. So 4 there. 1, 2, 3, 4, 5, 6, 7. It's really 9 total here. How is that? Yeah, 9 things. 6, 7, 9. So this is going to be 4, but then bilaterally. Okay, all right. Let's see what we have. Okay, nursemaid's elbow, aka elbow something, subluxation, annular ligament displacement, common pediatric joint injury in children ages 6 months to 5 years. Oh, so which head? Say head of bone. Oh, actually, the missing word is just a bone. So it's the radial head subluxation, annular ligament, abruptly pulling up on a child's hand or wrist, swinging them around or pulling. So it's the annular ligament. I think that's the big one there. Okay. Pronation and supination are motions of the blank, not the wrist. I'm going to say elbow because that's the PowerPoint. The biceps tendon is found within the, oh, now you're really asking, is found within the cubital tunnel? Not bad. Cubital fossa, we'll take it. Flex to about blank to palpate the Olecranon process. Oh, that's interesting. 90, 45, 70. Come on. 70? Why not just 90? That's too much, I guess. Treatment for nursemaid's elbow. So it's it's rapid something. Okay, so just hyperpronation. So this is supination. So it's hyperpronation. Oh, you can feel that. Supination flexion, a click may be felt by the finger over the radial head. So I guess there's two different ways you can do this. So hyperpronation or supination and flexion. Elbow range of motion, normal extension should be 0. This is extending would be going further than this, so it should be 0. Although some women can go to -15. That's crazy. Treatment for tennis elbow lateral epicondylitis. So tennis elbow is going to be lateral epicondylitis, main, and then something can be occasionally necessary. NSAIDs and maybe like pain injections, like cortisol injections. All right, so corticosteroid injection is that occasionally, but just rest actually. So no other kind of med or anything. Okay. Sign for cubital tunnel syndrome, which would be pinky and the medial end of your fourth digit, right? I don't know the sign. Oh, Tinel's sign? This guy's got a sign too? Or girl. I don't know who Tinel was. Oh, it's just tapping. Oh, Tinel's sign at the cubital tunnel. So it is tapping, but Tinel's test is for carpal tunnel. That's crazy confusing. So Tinel's sign is the actual tapping, which you can do over the cubital tunnel. I think it's just like right here. Tinel's test is for carpal tunnel. Okay. Psoriasis, dermatitis, herpetiformis, and erythema multiforme are most commonly found on which surface of the elbow? Posterior? Okay, why are we saying extensor? Posterior? Extensor surface. Okay. Elbow, note any deviations in the carrying angle. Normal is 10 range valgus. So normal is going to be a little bit valgus. I don't know, 0 to 10, 5 to 15, 5 to 15, we'll take it. Cubitus valgus lateral angle exceeding 15. So exceeding 15, we're going to have a little bit of valgus. So this going this way, 5 to 15 is fine. It's called cubitus valgus if it's more. All right, we'll take that. With ocrinon bursitis, that's of the ulna. So follow that back. It's just it's your elbow. It may be accompanied by warmth, tenderness, and erythema. What's the treatment? Ice. No, aspiration, which is both diagnostic and therapeutic. All right, cool. Cubital tunnel syndrome will present with paresthesia to what finger? So it's going to be it should be I don't know if it's your entire pinky or just the anterior surface, but it's the pinky, and then it's the medial end of your ring finger. So it is not bilateral, but bicidal, but that's correct. Okay. Blank elbow condition can be seen in conjunction with rheumatoid arthritis, pseudogout, ocrinon bursitis. Let's go, baby. CPDD. Calcium pyrophosphate deposition, which is called pseudogout. Sure. What nerve goes through the cubital tunnel? Isn't it ulnar? It's ulnar. Yeah, there we go. Let's go. Lateral epicondylitis. So this is going to be tennis elbow. Palpate the blank epicondyle of the distal humerus. Oh, it's the humerus. Lateral epicondyle. Tenderness is at or slightly distal to the, is just all the word lateral? Okay. Not my greatest card. Blank or tennis elbow, lateral epicondylitis, usually results from inflammation of origin of extensor carpi radialis brevis. I said this is lateral epicondylitis. Good. Okay, we do have tennis, carpentry, weightlifting, etc. Pain at the ulnar groove, plus or minus paresthesia, may suggest this has got to be cubital tunnel syndrome. But the ulnar groove? Is that this? Yeah, sort of. I think the ulnar nerve is also what our funny bone is. Yep. Okay. Medial epicondylitis. This is golfer's elbow, special test to confirm diagnosis. This, I think you have them flex, and then you resist their flexion. So you try to extend them, they hold their flexion. I'm pretty sure. Right? Yeah, resisted flexion. Okay. Blank or golfer's elbow. Medial epicondylitis. Blank's elbow, aka elbow subluxation. This is nursemaid's annular ligament. Treatment for nursemaid's elbow. Hyperpronation. So hyperpronation or supination pronation. I don't really, supination flexion, or whatever. Elbow range of motion, normal extension 0. Some women will demonstrate hyperextension to blank degrees. 15, negative 15. Lateral epicondylitis or tennis elbow usually results from inflammation of origin of extensor carpi radialis brevis. So that being an extensor issue makes sense. Blank epicondylitis, special test to confirm diagnosis. Pain may be revoked with resisted. So if I'm resisting flexion, this is medial epicondylitis. Medial epicondylitis or golfer's elbow. Okay, we get it. AKA elbow subluxation. So nursemaid's elbow is the annular ligament displacement. That's huge of the radial head. Lateral epicondylitis or tennis elbow usually results from inflammation of origin of extensor carpi radialis brevis. Actually, knowing that that's brevis is probably important because I think there's longus there as well. So we could probably add a card there. Also seen with repetitive extension motions. Yeah. So here we go. So lateral extensor carpi radialis brevis. That's important to know. The biceps tendon is found within the cubital fossa. Yeah, good. Nursemaid's elbow, aka elbow. So radial head subluxation. Yep. Treatment is going to be hyperpronation. Treatment for tennis elbow, lateral epicondylitis. Main, and then something can be occasionally rest, and then like corticosteroid injections. Sign for cubital tunnel syndrome is blank sign. Tinel's sign. So you tap. I thought you tapped here, but it looks like it's more. This makes more sense, right? Yeah, fairly certain. With ochronon bursitis, it may be accompanied by warmth, tenderness, and erythema. Treatment here. Oh, this is aspiration. Elbow range of motion, normal extension is going to be 0. Pronation and supinations are motions of the elbow, not the wrist. Flex to about blank to palpate the ochronon, 70 degrees. 70 degrees. Elbow, note any deviations in the carrying angle. Normal is going to be 5 to 15 is normal. If it's greater than 15, it's cubitus valgus. That is actually a good card to have as well. Cubitus valgus is when it exceeds 15. There we go, 50. Okay, 15 was both. Cubital tunnel syndrome will present with paresthesia to what fingers? So that's going to be pinky and then the medial end of the ring finger. Blank or tennis elbow, that's going to be on this side. It's going to be lateral epicondylitis. That's just all we want to know here. Often idiopathic, repetitive extension motions. Psoriasis, dermatitis, repetiforms, and erythema multiform are going to be on that extensor posterior side. Extensor nodules are most commonly seen in rheumatoid arthritis and gout. That's pretty important. Let's add that in. So we're on the elbow. Extensor nodules. Of the elbow. Extensor nodules are most commonly seen in rheumatoid arthritis and gout. In these two conditions, is gout autoimmune? Uric acid buildup? No, it's just an inflammatory condition. Interesting. In these two conditions, I mean, RA is autoimmune, yeah. So rather than recall just two diseases out of nowhere, classifying these I think is important. So we're going to say autoimmune and then inflammatory. We will recall both of those together, but then I want to do another one on the elbow extension. So the actual, this is important, like the word extensor or nodules, what's more important? I think I'm going to remember that I'm talking about nodules, but I think knowing it's under here is the most important. So we're going to say extensor as the other close there. So this will create two new cards. Oh, look at that. Here's one. Nodules, done. A good card. Okay. Of the elbow, extensor nodules are most commonly seen in these two conditions, rheumatoid arthritis and gout. I like to put some space in there. Good. Of the elbow, extensor nodules are most commonly seen in these conditions. Psoriasis, dermatitis, this is all on the extensor surface. I can make a similar card there. Pain at the ulnar groove may suggest cubital tunnel syndrome. What nerve goes through the cubital tunnel? Ulnar. Medial epicondylitis, special term to confirm. Pain may be provoked with resisted flexion. Elbow range of motion. Some women will have a negative 15 degrees. Can be seen in conjunction with RA, pseudogout, and gout. Ocranum bursitis? Let's go, baby. That's a harder question. Whatever. Nursemaid's elbow, aka elbow, so annual ligament displacement, common in children ages 6 months to 5 years. Resisted flexion is going, didn't we just do this? This is medial epicondylitis. Treatment for nursemaid's elbow is either hyperpronation or supination and flexion, kind of the reverse there. When the displacement is reduced, you may feel a click or hear a pop. Okay. Lateral epicondylitis, this is going to be tennis elbow. Palpate the lateral epicondylitis. It's pretty easy. Blank or golfer's elbow, medial epicondylitis, lateral epicondylitis, or tennis elbow. Usually results from inflammation of extensor cardi. Yeah, we'll do that. Treatment for nursemaid's elbow. The first one, again, is going to be hyperpronation. The biceps tendon is found within the cubital fossa, medial epicondylitis, or really love these questions. Golfer's elbow, aka this is nursemaids, that's subluxation. Lateral epicondylitis or tennis elbow usually results from inflammation of origin of extensor carpi radialis brevis. So extensor motions here for lateral. Again, extensor carpi radialis brevis, inflammation, and it's of the origin. Nursemaid's elbow, aka elbow, radial head subluxation, got it. Treatment for tennis elbow is going to be, is it the same as medial? This is just rest and then like steroid injections. See, that's a good question because I'm memorizing a treatment, but I need to, is it different than the other one? It's essentially the same, yeah. That makes sense. Sign for cubital tunnel syndrome, Tunnel's sign over the cubital tunnel, ulnar nerve. With Ocranum bursitis, it may be accompanied by warmth, tenderness, and erythema. How are we treating that? I don't think treatments are on this exam, but I still want to know them. That's aspiration. Elbow, cubital valgus is if it's exceeding 15. Cubitus valgus. We'll take it. All right. I think that's all I wanted to do for this morning. That's not bad. My next run, I'll knock out wrist and the hip, and then I just have to finish the things for the knee. I know a lot more than I did an hour and a half ago. All right.